Auzubillahiminash-shaytanir-rajim. Bismillahir-rahmanir-rahim. Assalamu alaikum. My name is Hani Siddiqui and my roll number is EP1770053. The topic of my presentation is Geriatric Urologic Disorder. So I'm going to start with the introduction. So first of all, we have sexual dysfunction. Sexual dysfunctions are highly prevalent in both sexes, ranging from 10% to 52% in men and 25% to 63% in women. As age progresses, there is a decrease in the sexual dysfunction. Sexual intercourse decreases from an average of once a week to once in 10 weeks, but the frequency of intercourse increases in elderly has actually increased over the past 40 years, but is still less than the young individuals. Elderly patients may experience physiological changes and encounter other interference with sexual activity because of disability, disease, and medications. Both men and women encounter different sexual dysfunction, like erectile dysfunction is the most common in men, and women don't participate in sexual activity due to poor sexual health. So here I have shared a pictorial illustration of a male sexual dysfunction. It is actually showing um, erectile dysfunction in men. So this is also the part of sexual dysfunction. So here we have aging man experience andropause, which is a type of a syndrome in which there is weakness, fatigue, reduced muscle and bone mass, impaired hematopoiesis, that is the production of blood and blood cells, oligospermia, sexual dysfunction, and psychiatric syndrome. The free testosterone level starts to decline at the rate of 1% per year after 40 years, and by the age of 60, 20% of men have level below the lower limit of normal. Sexual dysfunction is considered an interaction among motivation, drive, desires, thoughts, fantasies, pleasure, experiences, that is libido, orgasmic contractions, and ejaculations. Male sexual dysfunction denoting the inability to achieve a satisfactory sexual relationship may involve inadequacy of erection and emission. It is associated with neurological and physiological activity, and there are particular parts in the brain which are actually concerned with the sexual activities. Now here I have shared two pictorial illustrations. One on the left side, I have shown that if a person smokes, so he will ultimately experience erectile dysfunction, and on the other hand, I have shared some herbs which can be used for sexual head, like we have maca root, tonkat ali, and epimedium extract, and they are used in both man and woman sexual health. So here I'm going to discuss the erectile dysfunction. First of all, I'm going to start with the pathogenesis. Erection involves the neurologic, psychological, hormonal, arterial, and venous systems. In a study of 1,500 elderly men over a period of 10 years, organic erectile dysfunction was diagnosed. So now here I have used the term organic. What does it mean in medical terms? An organic disease is the term used to describe any health condition in which there is an observable and measurable disease process, such as inflammation or tissue damage. So, okay. So I was telling you that organic erectile dysfunction was diagnosed in more than 1050 subjects as a result of research in vascular. So the physiological, neurophysiology, neuropharmacology of the penis. Most urologists today believe that up to 80% of elderly erectile dysfunction cases are organic in nature. In most elderly sexual dysfunction studies, 50% involve vascular problems and 30% relate to diabetes mellitus. Then we have the neurogenic disorder. Erectile dysfunction can be caused by damage to the brain, spinal cord, cavernous or pudendal nerves, terminal nerve endings, and the receptors. It can be caused by diabetes, spinal cord injury, myelopathy, polyneuropathy, multiple sclerosis, etc. Then we have the vascular disorders, in which I have discussed the atherosclerosis is the leading vascular disease associated with male erectile dysfunction. The age of onset of coronary artery disease parallels the onset of ED, that is erectile dysfunction, indicating a generalized atherosclerotic etiology for the ED. As long as the arterial flow into the penis exceeds the venous outflow, the patient can be potent. Narrowing of the arterial lumen lowers the pressure in the cavernous arteries. Hormonal disorders. The incidence of erectile dysfunction with a hormonal cause has been estimated to be 5% to 35%, depending on which medical specialty is reporting the findings. The most common hormonal disorder in ED in elderly is diabetes mellitus. Approx 75% of elderly male diabetic experience ED owing to different other factors like vascular, neurologic, and psychological. So here I also have discussed the cause of erectile functioning. Like we have, if you are a heart patient, or if you are facing obesity, or the main cause, as we have discussed before, diabetes, and we have hypertension as well. So these are the leading cause of erectile dysfunctioning in men. So the causes are enlisted here. First of all, we have heart disease, then we have clogged blood vessels, that is atherosclerosis, high cholesterol, high blood pressure, diabetes, obesity, metabolic syndrome, that is a condition involving increased blood pressure, high insulin levels, body fat around the waist, and high cholesterol, Parkinson's disease, multiple sclerosis, certain prescription medications, tobacco use, Peyronie's disease, that is development of scar tissues inside the penis, alcoholism and other forms of substance abuse, sleep disorders, treatments for the prostate cancer or enlarged prostate, surgeries or injuries that affect the pelvic area or spinal cord, and low testosterone level. So what are the risk factors? As you get older, erections might take longer to develop and might not be as firm. You might need more direct touch to your penis to get and keep an erection. Various risk factors can contribute to erectile dysfunction, including medical conditions, tobacco uses, being overweight, certain medical treatments such as prostate surgery or radiation treatment for cancers, injuries, particularly if they damage the nerves or arteries that control erections. Then we have medications. Certain medications are also responsible for causing erectile dysfunctioning. The psychological conditions such as stress, anxiety, or depression, drug and alcohol use. So here is another pictorial illustration, and it goes around the man because it's a man thing. So as we can see that only 33% of men who suffer from erectile dysfunction seek help and advice about their problems because they are not comfortable in discussing. And then we have 2.3 million men in the UK suffer from erectile dysfunction, and it is also been thought that 20% of all the relationships are broken down because of this particular dysfunction, and male infertility accounts for 40 to 50% of all infertility issues. 1 in 10 men in the world are thought to suffer from erectile dysfunction. So here we have the complications which are associated with erectile dysfunction, and they include, as we know, that an unsatisfactory sex life, stress or anxiety, embarrassment or low self-esteem, relationship problems, the inability to get your partner pregnant. Here is another pictorial illustration: erectile dysfunction causes and treatment, and as we have discussed before, so it is just a pictorial illustration. Then we have gonadal function in erectile dysfunction. So we have gonadotropin, abnormalities of primary or secondary hypogonadism must be ruled out, particularly in patients with a decreased libido, with or without erectile dysfunction. Then we have testicular size and aging. Testicular size decreases with age, but its degeneration is sporadic. That is, it is not it doesn't happen with everyone, and it is infrequent, right? Thereby allowing most elderly men to maintain a normal or slightly decreased sperm output. Overall spermatogenesis decreases and is accompanied by an increase in serum concentration of FSH. FSH elevation correlates well with a decline in the number of Sertoli cells that secrete inhibin. Inhibin normally decreases FSH. Then we have testosterone. As a result of primary or secondary hypogonadism in the elderly male, available testosterone declines. Approximately 60% to 75% of circulating serum testosterone is bound to a beta globulin, which is a sex hormone binding globulin or testosterone binding globulin. Then we have the endocrine disorders. Many endocrine disorders can result in erectile dysfunction. Patients with prolactinomas, that is, it is a tumor which is present at the pituitary glands of your brain, commonly have ED, but prolactinomas account for less than 1% of erectile dysfunction cases. Prolactin inhibits the release of testosterone, resulting in secondary hypogonadism. Hyperprolactinemia may be more prevalent in diabetic patients. So here we have the signs and symptoms. Erectile dysfunction symptoms might include persistent trouble getting an erection, trouble keeping an erection, reduced sexual desire. We have some medicines that are used in erectile dysfunctions. The first things doctor usually prescribe to men with erectile dysfunctions are pills like Avanafil, Sildenafil, Tadalafil, Vardenafil. Okay, there are some medications that also cause erectile dysfunction, and here we are going to discuss them. Several general statements can be made regarding sexual function and medications. Drugs that affect libido generally have a central mode of action. For example, medications that block central dopamine transmission can decrease libido, and opiates have an anti-androgen effect. Drugs that alter hemodynamics may interfere with erection. Excessive sympathetic tone is thought to cause the Steele syndrome, which increases blood flow to muscles, drawing blood away from the erectile tissue. Drugs that block the peripheral sympathetic system can cause retrograde ejaculation or no ejaculation at all. Here is another pictorial illustration. Causes of erectile dysfunction: surgeries, diabetes, heart disease, alcohol, smoking, medication. Now here we have a case study. Sample name is sexual dysfunction, and description given is a 65-year-old black male with main complaint of sexual dysfunction. Subjective: the patient is a 65-year-old black male who comes into the office today with main complaint of sexual dysfunction. Patient reports that he would like to try CLS to see if it will improve his erectile performance. Patient states that perhaps his desire has been slightly decreased, but that has not been the primary problem. In discussing with me directly, patient primarily expresses that he would like to have his erections last longer. He reported that much less than half the time was he able to get erections during sexual activity, and only about half of the time he was able to maintain his erection after penetration. However, he only reports that it is slightly difficult to maintain the erection until completion of intercourse. Patient has no significant past medical history. He has never had any previous testicular infections. He denies any history of injuries to the groin, and he has never been told that he has a hernia. So he is not on any medications. Allergies: he has no drug allergies. Social: only occasionally drinks alcohol, and he is a non-smoker. And he currently is working as a nurse aide, second shift at a nursing home, stating He just was tired and wanted to take some time off. He states that he is in a relationship with one partner and denies any specific stress in the relationship. So we have the objective. General, he appears in no distress. Vital signs: blood pressure with last curve is 110 by 70 mmHg. Lungs clear to auscultation. Cardiovascular normal S1 S2 without murmur. GU, that is genital and urinary test. Testicles ascended bilaterally. No evidence of masses. No evidence of inguinal hernias. Assessment: sexual dysfunction. Plan: we will check a free and total testosterone level, as he does note some diminished desire, and the age factor is also there. He was given a sample of CLS, that is 10 mg, with instructions on usage and a prescription for that if that is successful. He will follow up here PRN, that is as per need. Lastly, I did give him a blood pressure recording card, as his blood pressure is borderline today. He will have that checked weekly at his workplace and follow up if they remain elevated. So I have shared the references that I have used in making this presentation. So at the end of my presentation, I would like to thank you for giving me a chance of preparing a presentation on this particular topic, and I hope you will like my presentation, and I hope that I will stand upon your expectations. And Allah Hafiz, Hani Siddiqui signing off. Take care.